Um, I think I break the silence and welcome you all as we are past 6 p.m. for Sweden and probably 5 p.m. And I think all the other zones we are connected right now, especially a panel which represents the various continents. So I have the privilege of welcoming you all for the Zoom webinar today. And I just want to share, I'm sitting right now, not outside, but up north in Sweden. So you have this beautiful background, which is talking of, which is showing nothing but snow. And right now it's snowing as well. We represent here the Swedish Society of Medicine, especially the Committee of Global Health. And this is one of our first webinars where we are wanting to discuss how the COVID-19 has impacted global health, and we would like to share perspectives from our colleagues around the world. And in that, we've also felt that since this declaration, many of the much of the global health research, financing, and some of the areas had to be somehow paused or rechannelized to COVID-19 because of its novel nature. However, the importance of investing in health has further got highlighted. And also the current discussions are giving us some kind of hope when we're thinking of building back together. And also what do we want to do collectively from around the globe to bring that hope post-positive COVID world or whichever way you want to count around it. So collectively together, you see my lovely panel up here, Professor Rosanna Peeling, Professor Anna Farah, and Professor Lida Elena, whom I will introduce you a bit better in a few more minutes. And I think just want to share these three panelists probably collectively represent more than 75 years of working experience, which ranges from research, science, and training, probably diagnostics, whatever we want to think about, you will hear further from how we go on. And along with that, I also want to kind of make a short acknowledgement that I'm aware some of our committee members are also present in the Zoom room right now with us. So on behalf of our entire committee, which represents the Swedish medical universities across the globe, across the country, we look forward to listening to our panelists today. Before we listen to each of our presenters, I would take a few minutes to introduce them so that I'm not interrupting them. Probably they can carry on with their presentations. And then once we've done with the presentations, we'll open up the floor for the question and answers to our audience here. So I start with Dr. Anna Farah, who will be our first presenter. Dr. Anna Farah, she has her medical degree from Karolinska, very much from Sweden, and she's worked around many different areas in Sweden before she returned to Karolinska for her PhD, and she's done it under the area of antibiotic resistance and antibiotic consumption in Sweden with focus on Escherichia coli. And she finished it around 2007, has worked around NGO, Doctors Without Borders, who does not know around that. And also she's worked in various other countries, especially in Myanmar around HIV clinics. Her return to Lebanon in 2008 led to the founding of the LAU School of Medicine, where she has been working very much around the microbiology and immunology and infectious disease curricula, both in preclinical and clinical settings. So Dr. Farah, we are looking forward to listening from you. Our second panelist, Dr. Lida Elena Sorio-Maya, she is from University del Valle, Cali, Colombia. So here comes South America. And she's trained and experienced infectious disease epidemiologist at PhD and trains at PhD and postdoctoral training with clinical R&D and has been a trainer of trainers in research for around good practice such as GCP, the good clinical practice, and effective project planning. Dr. Lida has strong links with health authorities at local and national level, which she has engaged by doing research in infectious disease of public health priority in Colombia. Initially, the research was generally conducted in malaria under the CDC collaboration in Cali and overall in Colombia, but more recently in dengue and other arbovirus diseases. She is responsible for the coordination of the PhD program at her university, which is University del Valle, which is the largest government university in that area of Colombia. Dr. Lida is based as the health faculty, and she teaches on epidemiology and research to graduates and postgraduate students. And currently, she's part of infectious disease research networks around malaria, dengue, and Zika, and is a member of the advisory group on COVID-19 response in Colombia. So welcome, Dr. Lida, and we're looking forward to listen from you. Finally, I come to our very experienced scientist, Professor Rosanna Peeling, currently the Professor and Chair of Diagnostics at the London School of Hygiene and Tropical Medicine. She's trained medical microbiologist, has been a research coordinator and head of diagnostic research at UNICEF, UNDP, World Bank, WHO Special Program for Research and Training in Tropical Diseases called WHO TDR in Geneva. And she is the chief of the National Laboratory for Sexual Transmitted Diseases in Canada before she became the diagnostic chair. Her research has focused on defining unmet diagnostic needs and facilitating test development, evaluation, and implementation in developing countries. She has established the International Diagnostic Center to simply advocate the value of diagnostics and fostering innovation which accelerates access to quality assured diagnostics. Currently, she is the member of Prize Advisory Panel for UK Longitude Prize, the European Commission Horizon 2020 AMR Prize, and Global AMR Innovation Fund. Very much concerned about the lack of capacity in critical decision has made Dr. Rosanna work for diagnostics in many different countries, and she has collaborated with Foundation Mario based in France to organize an advanced course on diagnostics, which has run over the last 10 years and has trained more over 350 policymakers in 80 countries. And very much, Professor Peeling is recipient of the YWCA Women of Distinction Award, an award for, and also a 5&R award for Canadian Leaders of Sustainable Development, and is the first woman scientist to be awarded the Royal Society of Tropical Medicine's George MacDonald Medal in 2014. With this diverse experience, backgrounds, research, and everything that on board, I welcome you all, and I welcome my audience here to our wonderful panel, and looking forward to hear from you. Dr. Anna Farah, you go first, and please share your presentation.
Okay, so good evening. I'm the clinician of the group. It seems everybody's very advanced. I'm a clinician. I work in private hospital in Beirut, in Lebanon, and I had a couple of questions asked to me for this particular webinar. So the first question was, what has been the major challenges that I faced in my clinical work during that? So to illustrate that, I really need to put you in the background of Lebanon and what Lebanon is. So Lebanon is a quite tiny country. We are around 6 million persons only. And it is, as you can see, located in the Mediterranean Sea, just north of Israel. So also, to understand the challenges we've been through in Lebanon, you need to understand the socioeconomic factors or what has happened lately in Lebanon. So, as you know, Lebanon has been through one major civil war from 1975 to 1990. And then there was a kind of recovery, a reboom, and the country has been doing rather well until October 2019, where, I mean, this is a country which has had quite a number of problems along the way. But in October 2019, there was a very big political uprising against the corruption of the country. And we went through a very rapid and evolving devaluation, inflation of the Lebanese pound. So in a period of a few months, the Lebanese pound at $1 was worth 1,100 Lebanese pounds. In October 2019, in March 2020, it was worth 8,500. You can imagine how the pop has been, and our buying power in our hospitals for all materials are really gone down. if we look at the pandemic, so already before the pandemic, had a number of March 2020, we had our first cases coming up, and the country was put completely under lockdown. We had a very severe lockdown. Everything closed. The town, the hospital, not the hospitals, the shops, almost everything was closed. Even the airport was closed until June, beginning of June 2020. In June 2020, the country opened up, and it opened up in a very haphazard and unorganized fashion, and things were rather okay over the summer. In August 4th, 2020, Beirut experienced one of its biggest, an enormous blast. This was, if you look at it globally, was the third biggest explosion in history that was non-nuclear, that devastated a very big part of Beirut. And of course, after that, you can see on the graph, the figures were low. And I think it was not because it was really low, but because of the blast, people were busy with many other things. And we were busy rebuilding Beirut, and we had no time to test. After that, up the pieces of Beirut, you can see that the numbers are rising quickly. And they've been rising sharply until, and there was no specific amount, or the measures were very unorganized. So they would close one of Beirut and not close the other. Shops and pubs would open, be allowed to open until 8 o'clock or 9 o'clock and then close. And then the next week it would be to 11. And then over Christmas and New Year's, options were because of this economic situation, and people came in. We remember Lebanon has a very huge diaspora. Everybody came in, and we are now paying the price. We are having huge numbers, and in January 2021, so just a couple of weeks ago, a complete lockdown has been put down again. Now, what has it meant to me in clinics? You need to understand, in Lebanon, up to 80% of hospitals are and of care is private. The government only holds a minor bunch, and they outsource a lot of their care to the private hospitals. Now, the private hospitals, even though they have to take on a number of patients from the National Social Security funds, etc., are very often not repaid for that. Now, what are the numbers? We have, this is what's happening here. So we have, we've had for the last few days, we've had 5,000 new cases a day. How does it look in my hospital, where we are completely full? What challenges we've had? So the financial situation of the country has been a major challenge for us. We have been, in the beginning, we had a hard time finding drugs for remdesivir, for instance. I have to ask my patients to go on the black market to get it. I don't need to do that now, gratefully, thankfully so. We have been running out of remdesivir. We had to take favipiravir. We've been running out of IL-6 inhibitor. We have to improvise and use tofacitinib instead. So we've had to improvise with medication also. Mind you, I am still working in a private hospital where people can pay for their medication. The unorganized lockdown has had a very big toll because we've had outbreaks in different settings. Also, the resource distribution is very unorganized. People that are being cared for are really people that can either know somebody or can pay for their care, etc. We've had medication shortages, as I said, and then the places shortages in hospital is really clear. We have a waiting list to our hospital now. People are being called in. We are out of respirators. Now, the other thing that I was asked was, what have I experienced that has been changed in my care? Now, I'm an infectious diseases physician. So for me, things have just increased and not decreased. But basically everything that is not COVID during this last month has been pushed aside. Elective surgeries have been closed. Outpatient clinics now are closed. We have been pushing for a telemedicine clinic because it is difficult to work when you cannot see your patients. I know that my colleagues, cardiologists, endocrinologists, etc., are having a hard time following their patients. Now, lessons learned, and the third question was, what have I learned? What have we learned from this pandemic? And what I have learned personally, or we have learned, is that we cannot stress enough on infection control. There's so much more we can do. There are resources that are available that we can use, and they could be more mobilized for other things like antimicrobial resistance. We have learned now that by sharing studies, this openness, we are learning so much as we go. We've never had this opportunity to have free papers available all the time. Having this flexibility in the guidelines is something that is quite new to us, as we are having guidelines that are changing constantly. What are my worries, my fears? Now, because of this flexibility in the guidelines and this working, so I can give you an example. Azithromycin that was used in the primary protocol that have been now proven not used for COVID is used still. I have most of my patients that come in, when we ask them, like, they tell me, like, doctors, I've already taken my azithromycin. I'm like, this is not in the protocol. So I can just imagine the toll that will come, like, in a few months when it comes to macrolide resistance or quinolone resistance. We are surely going to pay the price in a few months. I think also as well, when it comes to severe COVID, we are also being aggressive in using antimicrobials and antifungals, even though most of the time bacterial superimposition is not that great still. But when we have a patient that is bad, we have a tendency to use them anyway. So very briefly, because we have a very short time to present, this is mainly what I want to present, and I say thank you. And this is my team taking a picture, unfortunately with the mask, but no proper social distancing. So thank you from me. I'm going to stop sharing my screen now, and I'm going to mute myself.
Thank you, Dr. Farah. And probably now, Dr. Lida, can you please take over?
Thank you, Raman. I'm going to turn on my video first. Could you confirm that, are you able to see me and the presentation?
Yes, we can see the presentation, and you are not on the video yet.
Okay, I'll try again. Okay, I think my video should be on, right?
Yeah.
Okay. Okay. Hello, everyone from sunny Cali, Colombia. I'm very honored to be here with Rosanna and Anna. And I want to thank Raman and Lota for the invitation for this webinar. So I'm going to give my perspective on the impact of COVID-19 on global health. And I want to start with this very famous paper illustration that shows us how there was already anticipated excess mortality due to COVID, even the presence of interventions. So it was no surprise that, in fact, what we have observed around the world in largest cities in the capitals, metropolis of the world, like from New York to Jakarta to Italy, London, and here in South America, in Guayaquil, the incredible increase in the excess mortality comparing to the previous 5 years. We also have observed the same trend within the country. So this is excess mortality to the end of August in Colombia, with all larger cities like the capital, Bogota, to the smallest one like Quibdó that you see here in the other corner in the very vulnerable areas, all showing the excess mortality that was anticipated. So it was really, really a complex situation that was to suppress and mitigate this pandemic. What is clear to us in global health, and it was evident from the beginning in this pandemic, was in the inequities, in the impact of this excess mortality, whether they were ethnical, racial, or economic. This is the analysis of the socioeconomical strata of people that have died due to COVID in Colombia at that same report in August, and 90% of them were the lowest socioeconomical strata. So we know the impact of COVID is not equal, and the most vulnerable remain highly affected within and in the country and between countries. And how we respond to this, it has been incredible that we have this technological mind around the world. So the main response is still technological. And then for me, it was a shock from the real beginning when I was hearing, this communication, this message all the time about mechanical ventilators. And our president, the mayor of the main cities here were just telling the public how many ventilators they were buying and what were the challenges for them to get. Even in the US, for example, hospitals couldn't afford them, even in the US. So the response was technological, and not only technological, but also in the last part of the response, which is the intensive care unit. They had other responses in terms of technologies like apps. This is a snapshot of what I took, of a photo I took when I just wrote COVID in the Google Play. And there are so many apps there already that we are responded. But I think there was not much attention to one of the most important papers that I think it was in this epidemic from this group of clinicians in Italy. And they make this call very early in the outbreak that this was not an intensive care phenomenon. It was a public health and humanitarian crisis. And this is the way that we respond. With mechanical ventilators, and so is in cutting what is called the chain of transmission through testing, identifying positive cases, and tracking their contacts to interrupt precisely this transmission from even asymptomatic or pre-symptomatic individuals. And it has been successful in many countries. But as you could see in this graph, implementing these known efficacious interventions has different meanings in different scenarios. And even here, where they mention there are these blue areas where they supposedly have comprehensive tracing, I'm impressed that Colombia here is blue, or some other parts of the world are in blue, like having comprehensive tracing, where it's not totally so. So the other challenge that I see in this global health response, and to address better solutions for the future in global health, is the emphasis in local solutions. So you have these recommendations in what you do, but what it really matters is how you implement them.
Lida, if I interrupt you, it's possible you close your video.
Characteristic, yes?
Lida, this is me, Raman. If you close, yeah, you close your video. Thanks.
Okay, thank you. Thanks, Raman. So one of the issues that we have to deal with is the current global and national and local health systems, Already Anna mentioned how it has been challenging for them given this private and the funding of medical services. And we haven't mentioned yet all the underfunding of public health services, because we have been concentrating in how to finance disease care, but no prevention interventions. This is a very good document on rethinking the global health system. These are only the actors at global level, but we have seen how the WHO and other international agencies are struggling to unite the leaders of the world in a common and harmonized response that deal with the inequity and vulnerability of the populations, not only for vaccines, but for diagnostics, for PPE, etc. So leadership in global health is really an important part that we need to emphasize in the future of teaching global health. And it's not any type of leadership, but a special leadership. And I just want to use this, that was perfect for me to put in here. When we are in liquid times, in these very uncertain times, the leadership that we need is not that classical leadership with a single person, head that we all follow in their incredible ideas and charisma, but a leadership that engage all the experts, all the disciplines, that gives voice to those that are underrepresented, usually in the political scenario, that enable trust, respect for the different cultures, and built upon collaborative relationships. I think this kind of leadership needs to be not only at global level, but national and local level, and how these leaders emerge from the local experiences that are trying to deal with these uncertain times. I want to just leave that for discussion later. I'm looking forward to the interaction with you all. Thank you very much.
Thank you, Lida. Thank you for your presentation, and sorry for interrupting you. We were losing your voice, so that's why I asked you to close your video. And now we move on to Professor Peeling. She will take over her presentation now. Thanks.
Thank you. Thank you for inviting me to share with you some of my thoughts on how COVID-19 has impacted on global health. I'm speaking from a diagnostics point of view. Very early in the epidemic, the Director General of the WHO already urged countries to test. It says testing, isolation, contact tracing should be the backbone of the global pandemic response. And I don't think I need to tell this audience the role diagnostics play both for patient management to quickly identify cases and enable them to get the right treatment and appropriate care, and also to inform them to self-isolate, as well as the other bigger role at a population level for diagnostics to be able to map the location of cases, track the pattern of transmission, identify which are the hotspots or vulnerable populations that need special attention, as well as using a population-based data base to be able to think about, develop strategies for disease control in terms of lockdowns or restrictions, etc. Now, what is the reality? Sorry. I'm trying to get back to, yeah. So what are the realities? Very early on in the epidemic in April, WHO recommended against the use of any immunodiagnostics, meaning antigen or antibody tests. We all know that molecular testing using PCR or other amplification technologies to detect viral RNA is the thing to do. But many countries just don't have the capacity to do it, or have very limited capacity to do it. And for example, in the lower part of the slide, you'll see an algorithm that Peru has developed in order to use antibody tests to detect cases. We know that antibodies levels come up very quickly in coronavirus infections, and that when you don't have the capacity or you have a molecular capacity that's overwhelmed, using antibody tests is possible. And so they actually successfully managed to relieve the backlog of waiting time for molecular testing, and also using antibody tests to quickly triage those who are infected, prevent the healthcare system from being overwhelmed, and also put those who test positive into quarantine or isolation. The other reality is that the global competition for reagents for molecular testing or supplies and even swabs left countries with no access to testing. And so in the face of this, many countries had to innovate. And so for Africa CDC, they conducted training workshops for countries in a space of 3 weeks, which is unheard of in terms of being able to do this quickly. It just shows you we should never go back to taking months to prepare for a workshop. There's also much greater sharing and using online training methods and sharing data and updates. Now, in terms of lessons learned from this, I don't think we stopped learning yet. The pandemic is still unfolding as we speak, but COVID has really exposed fault lines and inequities in healthcare, as other speakers have already pointed out. And because of that, we are now in a situation where we're hearing from public health experts all the time. We're hearing from politicians that want to save the economy, and there's a lot of confusion as to what is the right thing to do. And in a pandemic like this, we have what I call the 3 Ps. We have public health experts, we have politicians, and then we have the public. And if the public doesn't follow what public health experts or politicians decide, we're nowhere with regard to controlling the pandemic. So we really need very clear messages for the public, and also that they need to trust what the politicians and the public health experts tell them. So in terms of lessons learned, no one is safe until everyone is safe. So we need greater global and sectoral cooperation instead of competition. And I refer to the competition for supplies of drugs, diagnostics, and vaccines. I refer to the sectorial collaboration between the politicians, the public health people, the people who need to for children to return to schools, to return to workplaces, for travel. IATA is now making policy about testing, and they've never had to do that before. But I hope that they don't just make their own decisions without consulting other people. And then the second biggest learning is we need more resilient health systems that could provide people-centered services built on the foundation of public confidence. And in terms of more people-centered services, we need people to be able to access services, health services, in different settings. And I put on the right-hand side of the screen all the different settings, either in healthcare settings or non-healthcare settings, that we're now using to test for COVID. And so we should think more about having this kind of access. Sorry. Can you see my slide?
Yes, we can.
Yeah, okay. Yeah, and then we need more resilient healthcare systems in order to have the surge capacity to do whatever we need to do in terms of production and distribution, and also provide a training and implementation of strategies, and invest in surveillance and sharing of data. So with that, I conclude my presentation.
Thank you, Professor Peeling, and thanks to all three of you for your wonderful presentations. And probably we can now, be on screen together. And I hope the audience has enjoyed listening to our panel and has started to get some thoughts and ideas, and probably they would like to ask some questions. If you stop sharing your screen, Professor Peeling.
Yeah, I'm trying to, but it doesn't seem to, I can't seem to do that. I'll try again, sorry. I can't get to my screen to stop sharing.
To that, I can say probably we all have become a bit more, I think, patient to our technical issues as well, because that's the way things are. So welcome back to the Zoom room where we are all connected to discuss how COVID has made an impact and probably how we can learn from each other. I think that would be an appropriate way of moving ahead. I hope our audience will get ready to ask some questions and they will start to flow in. Please write in the chat box if you want to ask any question in Q&A as well. So I can put forward your question to our panel. Maybe I can start, probably first question should go to our first presenter so people have not forgotten what was said. Simply, the timings of, as you presented, Dr. Farah, like how Lebanon was still under, the not ready to be with the pandemic situation and what happened, and how do you see that has made an impact for you to kind of respond? Can you share something more when you talk about that everything else is on hold and how just taking care of COVID is making not just public feel a bit vulnerable, but how you as the medical professionals are, responding to that with all the vulnerabilities around?
So I'm not sure I understood your question, but initially when we had initially there was a very big trust in the public, like Professor Peeling was discussing. They trusted the advice of the government, because the government had a health panel that they chose 6 very well-known physicians, and people trusted those. And in the first lockdown, it was perfect. People really abided, people accepted. And then once the lockdown was upheaved and the government went back and took their own decisions without consulting with this panel, this was fairly known, things went awry. Now, in the first lockdown, everything was on purpose, everything was closed, only elective surgery, etc. And because I think people lived this first lockdown where everything was closed and were like, see, and nothing happened. So when the second lockdown is happening, trust was gone. A lot of people thought, well, yes, COVID is like nothing. And now, and as we're speaking, we're living the Italian scenario. And the wave is coming. And although we had officially time to prepare, we did prepare. In my hospital, we did prepare to some extent, meaning that we have we had the time to build our negative pressure rooms. We had the time to enlarge our emergency room. This was not done in the same aspect as well in the governmental hospital. So we're in a bit of a mess right now.
Thank you, Dr. Farah. Thank you for your response. This questions from our audience has started to come in. Before I take that question, I want to just bring that to one question to Dr. Leader, because she mentioned something around the technological mindset with which this whole response has happened. And I want you to say a little bit more, how do you relate that to the technological response, and where do you fit your leadership? I mean, what would you do differently, probably, just from your point of view?
Yeah, I just want to share, thanks, Arman. I would just want to share, very personal feeling in one of these early meetings that I had with the advisory panel. And they were asking us how many mechanical ventilators they need to acquire to get this over. And I was like shocked, I couldn't respond. So I say, as many as you can with the doctors that you have and the nurses that you have and the drugs that you have. But it's not enough. That's not the question. We need to have a public health response. We need to protect the vulnerable, the people who's going to suffer because there are not going to be jobs, the children that are out of school. We need to discuss how to make the lives of these people that are more vulnerable, more where living, that they are not going to be impacted and they can abide to the recommendations, because one of the reasons they don't follow them is they can't. Yeah, they need to go to work and survive and find a living, even they are convinced. And I was talking to different economists, but they couldn't follow. I don't know whether I was speaking other language or what. And I asked them, is the economy really a social science? I don't understand. Or is it a technological science? It took several months to get the dialogue of how many ventilators, like second line, and then we need the testing, we need the contact tracers, we need all the other activities that we need to put in place and are difficult, but we need them quick. So I think it's another different mindset on how do you put the priorities and how you imagine the world is solved. Here we have what we call critical epidemiology, when they said, technology is what allows the world to move on as usual with all the problems. So I think they have that history has shown when you have technology allows you to carry on with inequity, with all these other things, but we don't have that here. And that was difficult to get that message through. So that mindset, it needs to be really, really pushed forward.
So I thank you for that answer, and I hope our listeners can relate to that fact that it's not only mechanical and how we need to think of, and probably a mind shift. So I take the question from our audience that has come from Sandra Zetterquist, and she's asking, probably I'll like you, Professor Peeling, to take that on. How has the world community worked for and against a united response to the pandemic? For example, the tests, the vaccine, the doses, and has any region been under prioritized, for example?
Yes, so unfortunately, especially at the beginning of the pandemic, it's almost like every country for itself, because we know we're all competing. And so the example that I showed of Peru using antibody tests, rather than molecular tests, is just that they were not able to buy any molecular tests, even if they had the ability to increase capacity. And Patty Garcia, who was previously the Minister of Health for Peru, called me and said, why is it that our dollars are not as good as dollars from other countries? We have the money, we want to buy these tests, but somehow we were ignored. But of course, it's not only Peru, right? John Nkengasong, the director of the Africa CDC, actually wrote an article in Nature to say, the heading is, Africa has been locked out of access to testing, cannot buy any tests. And it was only after that article that he managed to work out donations, as well as arrange for tests to be bought and sent to Africa. And I think that it also stemmed from some countries that are the major countries for production, wanting to make sure that everybody in that country have access first before they sent any abroad. And so that didn't help either. The nationalism was strong in some countries. And we're seeing the same with vaccines. Yeah. The vaccines, depending on where it's made, those countries have priority before the vaccines are sent to other countries. Yeah. But I hope now it's improving little by little. Yeah.
Thank you for that response. Professor Dr. Farah, would you like to comment on something in relation to this, like how vaccines are being prioritized, if you want to talk about Lebanon?
So in Lebanon, it was quite funny, because we had a law that any vaccine that was still some sort experimental was not allowed to be imported. So we had to change the law to be able to import the vaccine because it's a new vaccine, which has been done now. Officially we're importing the Pfizer vaccine, and private parties are allowed to import it also. But we have not gotten any information about the rollout, about what's going to happen. We haven't got any information about that yet.
Yeah, so thanks for that. I think probably many situations are like that. Professor Lida, would you have something to say on that in relation to vaccines quickly?
I think the vaccine is more of the technology response, and I would like to see more the discussion in a package of preventive measures that includes vaccines. I think this communication to the public is becoming very politically, how do you say, managed. Yeah. And the good governments are those that are already vaccinated, and the bad governments are those that are delayed. And I think that's not very healthy for the public health interventions that we need. So in fact, our recommendation is to talk about a package of preventive measures, which include vaccines to people that need them most, without getting all the hassle of the discussions about equity, which are very tough, because then people want to be first. And there are several reasons they want to be first. And also how include the other preventive measures and how we can remove those even in the presence of some level of vaccination. And I'm very advocate of COVAX in that we need to be together to negotiate, because business is business and people want to carry on doing business. Yeah. So we need to contrast that power because they have that at this moment. So being united to be able to negotiate is better for everyone.
I think that question has brought a few, I think, good things to come forward to us to kind of share. And I would like to probably bring that question in. Isn't it natural for countries that have developed indigenous vaccines to prioritize their citizens before others? And should that change in future? I would like Professor Peeling, you to respond on that first before we go further.
Yes, I think it's a natural inclination, and politicians would always want to make sure that they say that they prioritize their own citizens first. But what does it mean by prioritization? Do you prioritize everyone, or you prioritize the most vulnerable first? But in the meantime, share some with other countries so that they could also prioritize their most needed population for vaccines. So I think there has to be more conversations about how that works out.
And I would agree to that. And I just would take the same thing in a line that comes to come to us via chat function, Q&A. And it says, what would building back better, resilient global health infrastructure and supply chains require? So I think it's an interesting package question, which maybe I'll first ask quickly, Dr. Farah, if you would like to just mention something. What would it mean for you when it comes to having a resilient global health infrastructure from your point of view?
Oh, from my point of view, if there was you mean a coordinator, resilient that would mean a lot. But the problem is, because it's fragmented all over the world, and every country has his or her rule, you will have a very different impact in every country, as we are seeing.
So I think that question by Ibrahima Barrow somehow is interesting, but I think the discussion would allow you to think how we are looking at things which are not straightforward. So I'll pick on something by Monica Goodla, who's asking, now let's say we are talking vaccine, so somewhere this is the current scenario, so it will move to that with vaccine hesitancy. When it comes to how are the vaccines developed now, which have taken lesser time than those which were done before? And how is it received by the global public? Because, for example, in Sweden per se also, there are some who would not want to vaccine. And how shall one think of reaching them? I'll ask you, Dr. Lida, to mention on that probably. How would you think in a situation like that?
I'm becoming very familiar with memes now in the WhatsApp, and there is a meme where people is saying, we need a solution for this problem. And they said, here is the solution. Where is it? How fast you want it? Very fast. We want it now. Here is the solution. This is the vaccine. They say, ooh, too fast. That's the meme. We don't trust it. It's too fast. So one of the things is that it's incredible. I mean, the achievement of science, it's amazing. And we, as a society, as the world, had to be very proud of that. And I think it's not a matter of trust. I think people is sensible to ask questions, yeah, to be concerned. And it's real. We don't know what is going to happen in the meantime, in the medium time or the long time. And I think the way to approach it is just, I would say, from the very biased epidemiological perspective, the concept of risk. People don't understand really what is that probability. So if they see in the news someone got, Bell's palsy, or someone have allergic reaction, they stop. They don't want it, and they use it as an argument not to use it. But if we show them that that's out of 1 million doses or 10 million doses, they would be able to balance their own risks and benefits to make educating people in what it means to be vaccinated. They are taking a risk. Yeah. That's true, as we take it when we cross the street. But they need to balance the benefits they have for themselves, their families, especially the older ones, and as a community as well.
And I would only endorse that thought that we are all like, somehow we need to somewhere, think of the risks involved. Professor Peeling, you are very much involved in the, creation and generation of science, and probably science in the sense of like new methods. So how would you react to this, like in a very, I think in this place where we have many students and all of us attached, like how has this particular vaccine which has come, or many vaccines that have come in very short time, how do you justify that to young students that it's possible? Let's say, how would you think?
Yeah, I actually go back to several years ago when I was asked to co-chair a WHO committee on the R&D blueprint on how to innovate and deal with epidemics in the future. And the WHO invited presentations from vaccine companies, from drug companies, and from diagnostic companies to say, not only for development, is there room for more collaboration between different companies that have different expertise, different systems for developing vaccines and putting vaccines into different vectors? Would that collaboration actually result in accelerating the vaccine development and delivery? As well as other mechanisms for once you have the vaccine, the logistics, the supplies, etc. And a lot of very useful discussions came about because of that. And I think the world has been better in terms of industry collaboration because of that. But there has to be more of those conversations, because I think it's something that we all face together. And it's not industry alone, because if industry comes up with something new and nobody trusts it, we're still, nowhere, right? So I think more collaboration, more transparency in terms of what it can do, what it cannot do. The current vaccine, we still don't know whether it prevents infection or just prevents disease or just prevents severe disease, right? There's not a lot of information in the public domain. And that has to be forthcoming. But traditionally, those are all confidential information. And so that system needs to get changed. Over.
Thank you. Thank you, Professor Peeling. I think I will just, read what I have seen around questions that are coming to us. They're quite interesting, but because we are closer to the time to finish our webinar, because I can't keep you all more, you have many other things to do. I would like to read a couple of things which is coming, like the conversations around people who do not vaccinate. Shall they be punished? Shall there be travel bans? Probably a question for all of us to ponder. And I'm not sure if the panel has or we have a direct answer to that. And also the question around that there are 39 million doses of vaccines that have been already administered in 49 higher income countries, and very few in the, let's say 25 doses in one lowest income country. And that's what Dr. Tedros has said. So I think if you keep these questions, which we see in the Q&A and how they are seen in the chat, and listening to what our panel has tried to present from probably many different aspects, I think our collective way to address would be, as you hear, a lot more collaboration, probably a lot more transparency. And I would also say that all these wonderful panelists here, they are active teachers, they've been educators, they train, they've been in this field work themselves. And I think if you will look at Professor Peeling, who's been around many pandemics, and I have the privilege of working with them on different occasions, I would like us to come to one point where I feel the 3 Ps I pick up, maybe we all can think, the public health experts, politicians, and public. We all need to be in this together. And probably this is a time that's going to change how we can move on and try to answer the question around inequalities be reduced. I think I leave this not a question, but maybe I can have way to move forward that this also brings in our younger generation, our younger professionals who are seeing this very much in their, let's say time when they're training. How would they receive this experience, what has happened in 2020 and what we've learned from it? And I think some of these things would also spotlight Sweden. So I would be very liberal, not liberal in the sense just leave away. Sweden has been in spotlight when it comes to global health in terms of how we reacted, the trust the government, the trust like the way we've done things, but still the world has found us as a outlier. So let's all creatively and collectively try to look at what we've done together. And it's not that I need to speak a lot and share, but I think many of the things that all of us who've talked here, it's asking for one thing, probably more transparency, more collaboration, more communication, and somewhere a leadership that has, let's bring back the solidarity, which I heard from all of you, maybe not as defined, but in the way you've expressed yourself. And I think I also want to end today by bringing something which I would want all of us who are still in the webinar, that it's a very, very, I think, eminent woman leaders in infectious disease research, very much involved in clinical, in academia, and in diagnostics, and probably coming towards women in science, women in global health. I would like to thank you all for having this and accepting our invitation and being here today. And please, I think the communication goes on. Feel free to write to us if you have more questions, and hope we can get back to you and more with the interesting webinars. So thank you, Dr. Peeling, thank you, Dr. Lida, and thank you, Dr. Farah, for your time today. And thanks to SLS for hosting us. Thank you very much.
Thank you.
Thank you. Great.
Thank you. Bye, Rosanna.
Bye.
Bye.
Bye. Bye, Anna.